What are the biggest cases you're seeing now? Because you review incidents in the ER, right? When a code gray gets called or violence happens in the ER, you're reviewing the cases. What are some of the biggest problems you see? Like, where do you see the communication breakdown where you're looking at a situation that went horribly? Is there like specific things you see that occur regularly where you're like, it could have probably been stopped at this point, but this is where it went awry, or common mistakes that the nurses or the doctors are making, or that security's making in the situation?
On it, up to the most common, up to the rare, real wild situations, usually proximity, backing up. They start, they're at the exit, they're ready to put up a fight, and then we're like, ooh, care providers and security alike, they're like, oh, we want to shut this down. We're worried about all that other precipitating stuff. But that's when we need to back up, try to think more clearly. Mm-hmm. We're allowing their behavior to influence ours, and we're just going to fight or flight alongside them. And when we overreact, then that's when that's when several people start getting hurt.
Yeah. Give them a little bit of space. Mm-hmm. A little bit you don't have to be within arm's reach of the patient necessarily.
No, and not even sitters, not even when they're, on fall precautions. You need unobstructed line of sight, right? I mean, we could be across the room and stop a fall risk from 6-10 feet away. Mm-hmm. I can close that gap pretty quick. We don't need those sweet new CNAs, wanting to be future docs, future nurses. They'll sit right there and just let grandma smack them around.
Right.
So really just reinforce, back up and get help rolling. And we'll probably come up with a pretty good plan and start getting rolled. And now I heard you talked about codes before, how codes go south, right? You've been part of a good code blue and a bad code blue. So like what's going on in a bad code blue?
I would say it comes down to communication. That whoever's leading the code field or in the hospital isn't sure of what the next steps are, isn't making sure the whole team knows the plan. They don't know sometimes what the outcome is probably going to be, or even like, I don't know how to explain it well, but some of these codes, we're not going to probably get this person back. So let's do all the things we usually do, but let's also start to mentally prepare family and the staff for this eventual outcome. And if we get them back, great. But a lot of times if they're, if it's a code blue and it was unexpected or they came in by ambulance, we're probably not going to get them back. So let's make sure all the staff feels included on this decision making. Let's make sure everybody's comfortable that we're doing everything we possibly can and that nobody has an idea that they want to try that doesn't get a chance to voice it. But it comes down to communication. It's whoever's leading it is not communicating well enough with family, with staff, and it's chaos, and they're not bringing order to that chaos.
Yeah. And code grays by common nature can be very chaotic. And so we'll have a similar outcome. But what's going on now, not necessarily talking outcomes, because we don't get to dictate outcomes.
Sure.
But workflow. What's going on in a good code blue? Outcome regardless.
I'd say everyone knows their role. There's a clear delineation of who's leading the code, the provider. They're not just standing in a corner. They're actively involved in making sure everything's happening. They're communicating with staff. Now we're doing this. Now we're doing this. Now we're doing this.
So that's what we need in a code gray. Someone to take lead. And usually going to start with a nurse. But sure, we trust our paramedics, EMTs also to take lead. But notice I'm specifying, and by all means, trusty docs that want to step up. They just don't typically tend to lead the code grays, at least at the moment.
Yeah.
Work in progress, but and then assign roles. Who's on arms, who's on legs. Even though we're still hoping less than half are going to go hands-on.
Right.
But just in case for staff safety, right? Because if we skip assigning a leader and we skip assigning roles, and we're out here at the nurse station talking about a great therapeutic approach, the patient family, on occasion have thought we're talking trash, and they'll come out and attack. So that's why we put somebody on the door just in case. Mm-hmm. And then that gives us space and time. Let's give them space and time, because if you're stressing out, you want me to surround you with 10 people.
Right.
Right. And too many people, that's going to cause more distress.
Yeah.
So give those others roles, just like in the code blue. All right, who can support family right now if we have family involved, who can support neighboring patients, because behavior influences behavior. Your neighbors are always going to get a little extra needy after a code gray.
Yeah.
So can you be, so yeah, especially, I got a nervous little tech over here. I probably don't want her handling with the irate guy or person. I'd probably, hey, can you go see if grandma next door needs some water? Or get a warm blanket, right? She can do a little support care. It's going to make her feel good. Patients feel good. But yeah, let's get arms, legs squared away, and then that buys us time to talk about it. All the lesser interventions are pretty simple. But yeah, if it's going to come down to e-meds and, more restrictive measures because they're a danger to themselves or others, can we come up with a safe plan? And then sometimes we got to gauge the risk of doing something versus the risk of doing nothing. Mm-hmm. We have a lot of veterans in the area. And yeah, sometimes we don't come home totally whole. Mm-hmm. Right? So yeah, if I have an ex-Green Beret all flexed up on us, ready to go in the corner, I can't make a safe approach on that.
Yeah.
Right? I bet if we give him space and time, we can express that, right? Just get him out of that fight or flight sense. Don't join him in the fight or flight. Mm-hmm. Try to communicate, maybe try to find somebody specific to his branch. Even.
Yeah.
I say that with most branches, with the exception of Marines. Just get a box of crayons and M52. I say that with love. One of my brothers is a jarhead. But I don't know what it is about a Marine who's intoxicated. Good luck.
Yeah. Yeah.
Just give the guy B-52. We'll talk later.
What do you think works the best when there's a nurse or a provider that's interacting with the patient? They call a code gray. Maybe they're on their way to establishing some kind of rapport. They're sitting down in the room. They're not escalating the situation. They're not, standing in too close proximity and kind of a, aggressive stance towards the patient. Do you like to see, so a code gray gets called and security's on the way, staff, charge nurses, everybody's on their way. Is it better for that person to continue to try to de-escalate the situation knowing security shows up, I imagine? I guess my perspective is I'm not usually present for a lot of these. The nurses are calling them. Mm-hmm. I'm coming after the fact. And usually I'm not doing anything in these code grays. I'm ordering meds to sedate the patient. And I go briefly to make sure things are safe, security's there, and then I walk away. I'm not really standing there being involved most of the time. But if it was the person is at the bedside, they initiate the code gray, they could see this going south, should that person usually keep trying to de-escalate the situation, knowing security's back here? If something happens, they're going to be a rapid response. They're right outside the door. Maybe they haven't come and surrounded the patient because they can see there's no violence, but they could see it could happen.
Absolutely.
I mean, do you understand what I'm asking? I guess
totally.
For the standpoint of the nurses and, because a lot of times I imagine what happens is the nurse calls a code, they step out of the room, they call a code gray, then they kind of walk away and expect security to handle it from there on. And I don't know that that's, based on our conversation so far, I don't know that that's always the best approach to say, okay, you guys go tackle them. And that's not what we want to do right away.
No. If we're talking about a patient, we need clinicians to be at least supervising that treatment. Now, security does take our course alongside us. So we are at least, nurses, techs, security, behavioral health, house soups, they're all on the same page. And yet that's why I said we're looking to get the docs looped in. So they're a resource for us to use. And they are being directed to respond to a code gray, not rush up to the room. Just go to the side. If active violence is not occurring.
That's security's directive, right. Is
show
up to the room, there's no active violence.
A teammate's making some headway or some progress, or at least buying us time. Mm-hmm. So that's when the code gray leader, whoever takes lead of the event, starts assigning roles, get that security empowered to protect us. Because we got out of the term using hands off, so security got the memo like, oh, we're going hands off? No. If I ask a dozen of our peers to define hands on, everyone's going to have a different definition. So we're just getting out of the habit of documenting that. We want to specify we used our prescribed curriculum. We have initials for it, but since we're not advertising for them necessarily. But yeah, so we're going to use that curriculum, that skill set. So yeah, we're going to say, yeah, you can use your therapeutic physical skills as it's been taught to you, and we say it's a guide, not a handbook. So, there's wiggle room within it, based on the patient, the size, considerations, whatnot, and medical considerations as well.
Mm-hmm.
So, but yeah, we need to we're getting out of that habit of, code gray, get them security. Yeah, it's code gray. All right, now let's plan. Let's give them space and time if we can. Yeah, and yeah, if a teammate's buying us time by keeping them talking, fantastic. Let's come up with a plan in case this doesn't go very well,
Yeah.
And then, physicians, it's really simple. It's really honestly, behavioral health and nursing will tell you what they could use, can you give me B52 or Zyprexa or this or that or the other, combination of, but sometimes, every now and then we'll get a burnt out doc. It's I'm not reinforcing negative behavior. Here's one of Ativan. We're like, man, that's not going to do anything.
Right.
And who's to say this person's suffering is not the same as, right, somebody with a broken bone. We know they're suffering.
Mm-hmm.
We automatically give them pain meds of some kind.
Right.
Right. So that's what there's maybe some talks about, having some more meds at the ready for them.
And I think from the provider standpoint, at least I probably have some misconceptions about what a code gray means, because I think when a code gray is initiated, a lot of times my mind immediately goes to, well, I'm going to order some meds. We're going to sedate them. This is already a violent situation, and it's really not. We're still looking for at least half the time to de-escalate this, not sedate them, not restrain them, not have to go hands-on with them.
Yeah.
And I feel like in my mind, I hear a code gray, and I'm assuming that it's already deteriorated to the point where now we are going hands-on with somebody, and that's not the goal of a code gray. It's
not
really
now.
to be...
Hopefully it's to get ahead of that. Because,
Right.
that signs of anxiety or defensive, that could lead up to it. So that's when we want to get ahead of it, and, start making them feel better there and the team, right? Knowing that we have that additional support right there, that they're not just dealing with this all by themselves. So, maybe they're just being, nasty and racist with the staff. Right. So we just quick hey, doc, do you need to keep him?
Right.
All right. If they're not a danger to himself or others, then you're right. And if you're not worried about something else life-threatening, can we just go?
Right.
Or can we just give outpatient resources?
Mm-hmm.
Right. Cause we've had providers be like, "Ooh, I don't want to let them go because I'm worried about, they really need these IV antibiotics." They were like, "Well, doc, that can be done outpatient infusion as well." We're like, "Well, yeah, but, it'd be better with a PICC line." And the thing is, they have a history of addiction. Fair. So because of those choices now, they can just get poked every time.
Mm-hmm.
Sure, it is not ideal, but their choices led up to that. That is what's best for now.
Right.
Until maybe they make progress and, maybe their clinician, their mental health clinician supports something else down the road.
Yeah. It's no different than the patients that leave against medical advice, that aren't angry, that just say, I don't think I need to be admitted for this. What's the best next treatment for this that I can get outpatient? And we're like, well, this is less than ideal, but I'll prescribe you oral antibiotics for this as opposed to giving you IV antibiotics in the hospital. And we come up with a plan B. It's not the plan that I would prefer for them, but they have their own agency. And if it's the same with kind of an aggressive patient that's not a threat to themselves or others, they're deciding that, they're not going to be calm with the staff and they need to be walked out. They're going to leave. And we can come up with another plan for them to still treat whatever their condition is.
Yeah. 'Cause we don't always get a feel-good discharge.
Mm-hmm.
But that's why, staff aren't aware. We have a lot of other resources available to us, too, for those cases. 'Cause I've been on both sides of the fence. I've been like, forget that jerk. That's not okay. But then on one case, I found myself siding with the doc. Like, as society, we could do better. This guy could use longer-term care. But he's already burned his bridges from here to Seattle, with this behavior. Is it worth the emotional toll on our staff at this point? The burnout they're going to face? Because, the millions wasn't phasing us. The millions it was costing us in interventions. Who cares about him paying his bills or not? It's not our problem. Foundation can help us maybe. But What we couldn't afford was that emotional toll.
Yeah.
That staff we may never get back.
Mm-hmm.
Staff that were here for 20 years, that enough's enough. I don't feel supported. Like, our staff feeling supportive is one of our most important things.
Yeah.
Yeah.
Yeah, that's huge. Because, I mean, these scenarios are probably one of the biggest burnout in the hospital. Even the patients that leave against medical advice, I see staff getting burned out by that. Like, I can't believe they won't follow our advice and get admitted for this treatment where we can watch them super close. And I try to tell people, like, just take a deep breath. Like, they're not choosing the plan that I would prefer they choose, but we're still going to send them with prescription medications and close follow-up, and here's a referral to this specialist. Please come back if you're getting worse before you can see the specialist. And that's okay. You can't let that scenario burn you out just because they're not choosing the plan that we would prefer they choose. There's plenty of good option Bs where, you know, you can't get riled up over a patient not choosing our plan for them in every situation. You can't let that burn you out. Still be compassionate for them and be like, okay, I'm really sorry you don't want to stay. Let's come up with the best plan we can possible for you to deal with this in the outpatient world.
Yeah. You just, every time they visit, it's an opportunity to plant a seed, and you just never know when it might take root.
That's a good point.
You never know. I get humbled time and time again. Man, our own team continuously motivates me. I'm like, and it's my job to motivate them to make safer decisions. I love it. But so one of our security officers is a retired surgical tech. And after leaving for 10 years and making my comeback, you know, I'm catching up with old friends. They're, oh, hey. And she hears my name and she's like, are you Josh? The Josh? And I'm like, what are you talking about? She's like, do you remember me? And I was like, I felt it was important. And I was like, I felt bad for not remembering, but I've seen a lot of bad things, unfortunately. Because she's like, you supported me in one of the worst times of my life. I'm like, really? She's like, I came here as a family when I lost my child. And you and Zeke, he's still in the city somewhere doing great things too. She's like, you and Zeke, even though you were just security, you pulled me aside into your office while they were working on my kid. And I knew that wasn't your job, and I knew that was you going above and beyond. And so after she retired as a surgical tech, she said that's why she went into security. She's like, hey, you know what? I've fulfilled there. Where else can I help more now? And yeah, now she's one of our security officers, you know, second chapter in life.
Well, that's awesome.
Like, you just never know when that seed might take down the road.
Yeah, that's awesome.
Yeah, so it's just remember that. Yeah, if we don't make their problem our problem, and just keep trying to give that great customer service, we can handle most things with great customer service.
Right.
Yeah, I've handled some possibly nasty situations with just great customer service.
Right. Yeah, looking at them as human beings, not just a number. And yeah, it's easy for us to forget that, I think, far too often.
Yeah, definitely. Especially with what we're going through day to day.
What are some of the core principles that you teach about de-escalation? Things you would tell if we had a room full of techs, nurses, doctors. What are some of the core things that you think are important that maybe they don't know?
Once again, I really like to simplify because obviously, you know, there's text and books, you know, verbal judo and lots of great ones out there. But what they're all going to pretty much agree on is great customer service. You know, like, you know, the current curriculum says, you know, we use care, welfare, safety, and security is the guiding philosophy. And under care, it expands to, you know, respect and dignity. And I was like, yeah, if we fail at respect and dignity, we're going to fail in our personal life or our professional life. Right? So just great customer service and empathy, trying to understand this could be the worst time in their life. Right? Not sympathy. They could care less how you feel, maybe. Right? Or how you feel doesn't matter right now. Right? So just, it's an opportunity. Let's fight to understand, not fight to win.
What is the current climate as far as, so a patient gets placed on a hold, you know, in our system, it's an M1 hold. The providers determine this person's either a threat to themselves or someone else. And they decide to try to bolt from the ER. Is that a immediate we're going hands-on to keep this person in the hospital?
No longer. No.
Okay.
Because right now you're saying they're bolting. They're on their feet. Not even a SEAL team can stop that individual of any gender, size, or ability. Right? Somebody running at full speed, there's a lot of risk to you and I. Right? So just intensity and severity.
That's usually, I imagine, when the most violent incidents happen, when a nurse or anybody tries to get in their way.
That old school approach of let's do whatever it takes. And I was like, so I was like, hey, take a breath. Like, we don't got to do that anymore. Your safety comes first, yet we will provide for them and help them when we can safely do it. And 90% of the time we can safely manage all these situations, but there's 10%, maybe it's too extreme. They are too big and strong. They are too high or too much in psychosis. Right?
Mm-hmm.
So maybe it's best to give it space and time, call 911, see what they can do. And now, right, we have crisis teams out there. We have clinicians with our organization riding alongside local law enforcement agencies or fire departments trying to get ahead of these things. Mm-hmm. Man, those crisis teams take so much pressure off the EDs.
Yeah, they're phenomenal.
On the front end. And now they're even starting to do it on the back end too. Mm-hmm. They're like, hey, are you having any barriers getting to your appointment? Because it's just, once again, that community connection. We're like, oh, I don't got a car. This. I'm like, hey, it's cool. We'll get you a bus pass, or we'll get you a med ride provided by your insurance. Mm-hmm. Just connecting them to those resources they have. Man, and I was amazed. Like, sometimes there's no reason for them not to thrive. Mm-hmm. I mean, I had clients out the community, if they had their food stamps, they had their health insurance, housing paid for, any 7-Eleven job they could thrive on. Mm-hmm. If they have that. But just like any health condition, you need a reason to live.
Yeah.
Right? So it's just, and that's where the community connection comes back. They got to have a reason to live, a reason to want to get sober, get clean, or put the carbs down or whatever.
Right.
Right? You got to have we got to try to get them the why.
Yeah.
Just like, and that's all we're trying to do with that code gray. Let's figure out the why. What's the reason for their behavior? What's the want or need here? Yeah. Maybe we can eat. Yeah. Like, there's a regular likes to rip his IV out 4 or 5 times a visit, and it just took a PCA to be like, hey man, why do you keep pulling your IV? It's like, oh, that's the only way I could get people to pay attention or talk to me. He was living with homelessness. Oh. I'm like, does it justify his behavior? No. So we got to make sure we don't justify their behavior for them. Right. We do it all the time. But is it easy enough intervention? Totally. Right. But even then, for those that came into the ER, I'm here to save lives. I'm not here for that touchy-feely stuff. I had one lady, she was biting, spitting, combative. And the only reason she was acting that way, her insulin pump stopped working. That was all. And if we had a zero tolerance for violence, be like, we don't put up with that, get out of here. We would have lost her. Mm-hmm. It would have been a sad tale. Yeah. For sure. So, right, that distress behavior is the human distress signal. Mm-hmm. So it might be behavioral, but it could be a medical emergency. Yeah. And it's interesting to see those biases sometimes. I saw it from a med student once. And then I had a doc outside the door trying to educate, diabetic noncompliance is usually the diabetic's fault. And I was like, hey, I'm not a doc, but they have an insulin pump that died, I heard. Right. They're like, oh. And I was like, and I heard he's a med student. And his girlfriend, the other med student, called this in.
Yeah, checking your biases is huge, because especially when we get report from the EMS crews. I mean, I was a paramedic for a long time. It was easy to write off whatever the patient was coming in for, like, this is nothing. And then it's easy to pass on that bias to the doc when you're giving them a report, like, they've called us 5 times this week. It's never anything. They're just anxious. And what those crews don't often see is we later diagnose them with a pulmonary embolism. Like, they're feeling anxious because there's a blood clot in their lungs, or they're having abdominal pain because turns out they need their appendix taken out. And, they don't get to see that follow-up care of, like, sometimes there's actually an underlying emergency that if you write them off and pass on your bias, like I had a patient not that long ago, crew passed on their bias, said this is vomiting, diarrhea, this is just gastroenteritis, they got food poisoning or something. I can't believe they made us bring them in by ambulance. And I usually check myself when I get that bias from the crew. I actually order a bigger workup because I know, okay, they're influencing me. They've written this patient off. So now I'm going to actually order more than maybe I would have normally, to check myself to make sure I'm not getting influenced by that.
Let's break this cycle.
And the mom came in later, and I evaluated the patient. I was like, this probably is just gastroenteritis. We're going to check labs, do the usual stuff. I don't think she needs a CAT scan. Her abdomen really feels pretty non-tender. And her mom came in, and she's like, she is never like this. She's saying that she has really bad abdominal pain. This family member had appendicitis. I'm really worried she has appendicitis. I'm like, okay, I don't think we need to, radiate her abdomen. She felt nice and non-tender for me. But if that's really your concern, we can get the CAT scan. The risk is it's radiation to her abdomen. She's young. Yeah. The more CAT scans you get. But
risk versus reward, how bad is that risk?
Right.
It's fairly minuscule.
Yeah. And this mother's intuition, sure enough, that's, of course, sometimes the moral of the story is it's appendicitis. Yeah.
Or sometimes the patient knows themselves best.
Yeah.
Yeah, but we've just seen so many cases where they didn't, right? Or we thought they didn't.
Yeah.
Yeah.
But even if nothing else, I said, you know what, if you guys need this for your own peace of mind, let's CAT scan her, make sure this isn't her appendix. And, of course, I've learned to trust mother's intuition when they come into the ER with their kid.
There's something there.
Yeah, there's something there with mother's intuition.
There's something there.
Yeah, and especially
I've supported clients that didn't have their parents growing up. Whether it's mom or dad, missing one of your biologicals, it's just a gamble.
Mm-hmm.
If they're going to learn to accept love or even give love correctly moving forward. So man, it's a powerful thing. It's crazy.
Yeah. Yeah, and even the opiate addicts and, the patients with psychiatric emergencies. I was talking to a doctor on here not long ago that he lost his kid. She had a terminal illness at birth. I think she was 9 months when they lost her. And so he started drinking to recover from the pain. And he said, and then he was like, I'm a doctor. I can't be showing up intoxicated. Started writing himself opiates, using patient names, got found out, lost his license, was still addicted to opiates and was homeless for a period of time. And he had a physician friend that started writing him for Suboxone, and he actually recovered his whole life. He got his license back, but none of us are that far removed from some of these patients.
We're not.
It's usually a horrible life story. Something bad happened. They chose coping skills that any of us potentially could turn to. If any of us lost a kid, I was like, I can't even fathom that. Losing a kid, I could never say I wouldn't turn to alcohol or drugs. That's such a devastating thing. And we're not that far from the homeless, drug-addicted patient. Mm-mm. You just don't know their life story. You don't know what happened to them. And that kind of helped me have a little more empathy for these people because it's so easy to be like, they just don't have good morals. They have no willpower. And that's not really the problem. It's something happened to them, and this is how they're coping with it. And they have this underlying need and want, and they may have a genuine emergency today. How do I make sure that I'm not stuck in this bias that's going to miss something like that?
Yeah. And that being said, so even I realized, my last job, I was running a security team of 140 officers. And I couldn't even talk by the end of the day.
Yeah.
So it was but I know I'm complicated. And I was like, well, I need to be in a position where I can help people, though. And so that's why I took on this job. But eventually I'm going to have to step away. I'm like, it's still hard to hear our friends not making it home from their shift. Things going sideways still. So eventually I'll need to step back again. Once I feel this is sustainable and someone's replaced me. But that's why I want to go back into the community. I want to do, what have we always done as humans to get through times of war? We'll stop in times of war and throw a baseball game, football game, soccer game, you name it.
Yeah.
Right? We'll play a stupid little game. And I would take gangsters out to the pickleball court. I'm like, hey, let's see. I was like, MJ could play anything, could you? Like, all right. We play this one. I'm like, hey, what'd you think? Was it that hard? And they don't even really comment on the sport. They're like, man, people are friendly. I was like, yeah, when we share a common goal, something even simple and stupid as a game, I was like, yeah, people can be really friendly. It doesn't matter. So I'd like to eventually get back to a good old-fashioned community center, but on steroids.
Yeah.
Where we can celebrate our youth, have a safe place for teens to actually go after school. Other places to get coping skills, right? So everything from the competitive existing sports we already have the want and need, right? We have hockey, football, basketball, you name it, but also the community friendly for all ages, the, pickleball or even bingo night with grandma.
Yeah.
You know what I mean?
Yeah. That's such a huge
where staff
point.
could get in touch. Like my dream would be to, after a staff goes through a tough situation, be like, okay, automatically, you're going on a week's paid leave at least, maybe longer. Ish. It's not really paid leave. You're going to go to work the community center. You're just going to patch up wounds or whatever, little first aid. But please join some volleyball, play a pickup game, whatever. Get out there and interact. Why do you do what you do? Because usually, and that's why I like to ground my teammates when they're really stressing out. They're like, I'm sorry. I'm like, they're apologizing for something they went through. And I'm like, whoa. Why do you do what you do? Usually it comes down, I want to help people. Okay, but we cannot help others until we take care of ourselves.
Yeah, 100%.
Right.
Yeah, you can't go take care of patients until you've taken care of yourself.
Yeah, and that might be why ED is another hotbed too.
Mm-hmm.
How many shifts have you went through without eating?
Yeah.
Right, hangry is a fact.
Yep. Not hydrating.
Hydrate or die.
I tell people, like, nurses are like, I've had to pee for the last hour. I'm like, go. There's almost never a scenario where you can't go use the bathroom for 2 minutes.
Sometimes you got to make it happen. Mm-hmm. Have a teammate cover something real quick.
You're not thinking well with a full bladder anyway. Go use the bathroom.
or dehydrated. Yep. Every survival curriculum says do not ration water. Hydrate immediately so you make better decisions and maybe find more water.
Yeah.
Moving forward.
Yeah.
So hydrate, eat a little something, take care of yourself on shift, but then also when you get off shift, why did you pull that overtime in the first place? To get up to the mountains, to take the family camping?
Right. Well, I think you talk about the community stuff, and after an event, getting them something back out in the community, I think would really avoid a lot of the cynicism that we all develop after those scenarios, and that's what burns people out and why people leave healthcare is you get so cynical, and now every patient is that last patient encounter you had. You can't see the good in anybody going forward when you're cynical from this last scenario. You have to do something to heal from it when a scenario goes south, because then you're going to see bad in every human, and there's something to seeing the good in everybody, even the opiate addicted, the alcohol intoxicated. If you can see the good in somebody, you can take much better care of them and see the wants and the needs that they actually need from the healthcare system versus just writing them off. This alcoholic just has no willpower. I can't believe he's been here 5 times for alcohol withdrawal or alcohol intoxication. And I just feel like it's helpful to see that some of us are not that far removed from that scenario.
Right. And don't just leave the ED. I was friends with a provider, left the ED. Got to get out of here. But they just kept repeating the same cycle and saw everything in private and personal just falling apart.
Yeah. Yeah, the skills you need to survive. I mean, the ER, I feel like everything comes to a head. I mean, it's an intense environment. We are dealing with super high sick people, super high acuity sick people, and violent people, and psychiatric emergencies. Like, it escalates everything. And so if you have something about your mindset, or you're not taking good enough care of yourself, it's going to manifest when it's put under a stress test. If you're not hydrating, you're not exercising, you're not eating well, it's going to come to a head when you're on a busy shift and you're not thinking clear and you're pounding energy drinks and soda, and you're not going to be your best self, and it's going to test you. It's going to be a stress test that reveals your inadequacies and your bad mindsets, and you're not taking care of yourself, and you're not having a community. It definitely puts you under enough stress that the ER is not the place to let that stuff go.
Right. So yeah, I mean, I get it with, the new grads trying to get stuff knocked out, trying to, I did it especially in the military, like, I'm here for you, whatever you need. But eventually you got to slow that down and shift. I'm like, all right, yep, whatever you need, as long as also it complements your personal life, whether it's a family life or hanging out with friends or golf club or whatever recharges your batteries, as long as you can still get to that and keep doing that, like, you should be all right.
Yeah, 100%. But I like having people on that have like an underlying message And you've got a great one, so I'd love to have you back on, because I mean, we could talk about this stuff for hours and hours. Cool. Well, thanks for your time, Josh. I appreciate it.
I appreciate you.
Yeah, thank you.
Cool.